The management of intussusception in adults. A comprehensive discussion. Welcome to the Everything Surgery podcast, where today we delve into the complex and intriguing world of adult intussusception. Intussusception in adults is a rare clinical scenario, representing only about 5% of all cases of intussusception and accounting for roughly 1 to 5% of bowel obstructions in the adult population. Its management significantly diverges from that in children, primarily due to the high probability of an underlying pathological lead point. Let us begin by contrasting adult intussusception with the more familiar pediatric presentation. In children, intussusception is usually idiopathic, most often resulting from lymphoid hyperplasia and commonly presenting as an ileocolic type. The classic triad, abdominal pain, red currant jelly stool, and a palpable abdominal mass, is frequently observed in the pediatric group. Non-operative reduction, either by pneumatic or hydrostatic enema, is generally the first line of treatment. In contrast, adult intussusception is nearly always associated with a pathological lead point, with more than 90% of cases exhibiting this feature. The typical types seen in adults include enteroenteric, involving the small bowel, and colocolic forms. The clinical presentation in adults is usually subacute, chronic, or nonspecific, with the classic triad being quite rare. Symptoms can be intermittent and may include abdominal pain, which occurs in approximately 80% of cases, nausea and vomiting in about 40%, and altered bowel habits. A palpable mass is found in only about a quarter to half of cases. Laboratory studies offer little specificity, often only indicating dehydration or anemia. Therefore, imaging becomes pivotal. Computed tomography scanning is the diagnostic tool of choice, with sensitivity and specificity both exceeding 95%. Computed tomography can confirm the presence of intussusception, pinpoint its location, characterize the target or sausage-shaped mass, and frequently suggest the nature of the lead point, such as a mass lesion. Ultrasound may reveal the classic target or donut sign but is highly operator-dependent and may be limited by patient anatomy or intestinal gas. Plain abdominal radiographs might show signs of bowel obstruction but are not specific for intussusception itself. When it comes to management, the cornerstone in adults is surgery. Unlike in children, where reduction is often attempted first, the standard approach for adults is to perform a resection of the affected bowel segment, especially when a pathological lead point is likely. The surgical strategy is influenced by several factors: the location of the intussusception, whether in the small or large bowel, the suspected cause, benign or malignant, and the condition of the bowel, particularly the presence of peritonitis or ischemia. A critical controversy in surgical management is whether to attempt reduction of the intussusception before resection. For colonic intussusceptions, the risk of disseminating malignant cells or causing tumor embolism is high if the lead point is a carcinoma. Therefore, the current standard is to perform an en bloc resection without prior reduction. In the small bowel, if imaging suggests a benign cause such as a lipoma or benign stricture, and the bowel appears healthy, careful reduction followed by a limited resection may be considered to preserve bowel length. However, if there is any suspicion of bowel compromise or malignancy, resection without reduction is safer and preferred. Specific surgical approaches differ based on the segment involved. For small bowel intussusception, if a benign lesion is suspected and the tissue is viable, reduction followed by removal of the lesion or a segmental resection can often be performed using minimally invasive techniques. If malignancy is considered or the bowel is not healthy, an oncologic segmental resection is undertaken. For large bowel intussusception, the standard of care is a formal oncologic resection, such as a right or left hemicolectomy, without prior reduction since a significant proportion, up to 70%, of colonic lead points are malignant. The resection is performed en bloc, including the affected bowel segment and its associated mesentery. Laparoscopic surgery is gaining popularity for both diagnosis and treatment, providing excellent visualization and allowing for minimally invasive resections in selected cases, especially those involving the small bowel with benign causes. Open surgery remains the preferred approach when there is peritonitis, significant bowel distension, hemodynamic instability, or when a large malignant mass is anticipated. Non-surgical treatment options, such as enemas, have an extremely limited role in adults and are generally not recommended. This is due to the high incidence of pathological lead points that often require surgical resection for both diagnosis and cure. The risk of missing a malignant tumor, and the increased danger of bowel perforation during non-operative reduction. Only in highly selected cases, such as transient, idiopathic intussusception seen on imaging without signs of obstruction or a pathological lead point, or benign, appearing enteric intussusception related to conditions like celiac disease, might a conservative approach be considered. Understanding the underlying cause of intussusception is essential for long-term management. Malignant lead points are most common in the large bowel, with primary adenocarcinoma being the leading offender, followed by metastatic tumors such as melanoma or lung cancer, lymphoma, and sarcoma. Benign causes include lipomas, adenomatous polyps, Meckel's diverticulum, adhesions or strictures from conditions like Crohn's disease, and post-surgical changes. Idiopathic cases are rare and more frequently found in the small intestine. In summary, the management of adult intussusception requires a high degree of clinical suspicion and a systematic approach. Computed tomography is the gold standard for diagnosis. Surgical resection remains the primary treatment, with the surgical plan tailored to the location and suspected cause of the intussusception. For colonic cases, en-bloc resection without reduction is the rule, while a more nuanced approach may be taken for small bowel cases if benign disease is suspected. Finally, histopathological examination of the resected specimen is mandatory to guide further oncological management. Thank you for joining us today. If you found this discussion helpful, please like, share, and subscribe to the Everything Surgery podcast, where we continue to dissect the extraordinary in surgical practice.